We're going to be talking about PARP inhibitors in prostate cancer. So let's talk about what's called the homologous recombination deficiency. There are many ways in which DNA can be repaired. These include base excision, also includes a nucleotide excision repair, and then you can have both double-stranded as well as single-stranded reannealing of DNA. The HRD phenotype is characterized by the inability to accurately repair DNA, double-stranded breaks, using this homology-directed repair. So why is this important to prostate cancer? Well, cells with HRD are sensitive to PARP inhibition. This is what's called synthetic lethality. The dual cytotoxic mechanisms of PARP are inhibited by PARP inhibitors, and you can inhibit base excision repair by catalytic inhibition, and PARP trapping of DNA, which will also induce double-stranded breaks. So the DNA is not repaired, and the cells can then apoptose. So there are 4 PARP inhibitors that are available. The important thing to know is about a quarter of metastatic castration-resistant prostate cancers have DNA repair alterations. The gene alterations can be truncal or subclonal. Truncal means that it affects most of the cells, or if not all the tumor cells. Subclonal means there's a small population which can occur through mutations, and these are generally somatic. Prostate cancer cells with DNA repair alterations, as I said before, are sensitive to PARP, but they're also sensitive to platinum-based chemotherapy. And the real question is, can you salvage a patient who's progressed on a PARP inhibitor with platinum treatment? There's really no good answer to that question. On the right-hand portion of this slide, we have the different PARP inhibitors that are used in clinical practice, and basically showing the relative inhibition of the different PARP enzymes, and also the relative PARP trapping in relationship to olaparib. As we see, the one thing that I think distinguishes itself is that niraparib has a greater inhibition of PARP3, and talazoparib has more PARP trapping than the other PARP inhibitors. Whether this really makes a difference clinically, we really don't know, but it may play into the resistance pathways of some of these drugs. And we really don't know if these are cross-resistant drugs or not. So can you sequence PARP inhibitors in this situation? The answer is unclear. So in terms of castration-resistant disease, the FDA, there are FDA approvals of both olaparib and rucaparib as single agents. With the FDA for olaparib, deleterious or suspected deleterious germline or somatic HRD-mutated mCRPC is where this is indicated. This progressed after enzalutamide or abiraterone. So you don't need to receive taxane-based chemotherapy to receive olaparib. Rucaparib is a little bit different, and these are deleterious BRCA mutations, so it's not all the HRD mutations. And the patients have to have failed both an androgen-directed therapy as well as a taxane-based chemotherapy. So it's a slightly more advanced group of patients. We all continue the androgen deprivation therapy in these patients, and we treat these patients until either unacceptable toxicity or progression. And below, the NCCN has similar guidelines for the PARP inhibitors. So these drugs do have toxicities, even though they're oral agents. We have to monitor the patient's blood counts, so you can develop hematologic toxicities such as anemia, thrombocytopenia, neutropenia, nausea. That's a big problem. You can use antiemetics for patients to help prevent nausea. Fatigue and asthenia. You can see some LFT elevations as well. And what we do is we treat grade 3, or we interrupt treatment for grade 3 or 4 adverse events. You can then dose reduce, or if the patient really is not doing well, you can discontinue the treatment. But dose reduction often helps with these particular side effects: transfusions, colony stimulating factors, and then of course you manage the toxicities based upon the patient's overall outcome. How do we sequence PARP inhibitors? Well, some important data from Triton-3. Triton-3 was a randomized trial which took patients with castrate-resistant disease, deleterious or somatic germline alterations, and really only 3 different mutations: BRCA1 or BRCA2 or ATM, They had to progress after an ARPI in any setting, and they had to have a good ECOG performance status. So these patients were randomized to rucaparib at 600 or physician's choice. So this is pre-chemotherapy. So if we look at the BRCA-alterated groups, we see a very, very nice trend. The hazard ratio for progression-free survival is 0.5. The median radiographic progression-free survival is about a 5-month difference in favor of rucaparib versus physician's choice, and that could either be taxane-based chemotherapy or a next-generation anti-androgen. Unfortunately, and this is actually a common theme with PARP inhibitors, we don't really see great activity with the ATM. It's not any much different than the dealer's choice standard of care. So ATM is really not necessarily different than what we see with other agents. Question, of course, is sequencing. We really don't have an answer from that, but ATM, even though it's approved for this group of patients, is not necessarily as sensitive as the BRCA1, BRCA2s. So if we look by physician's choice, this is not a surprising slide. We see on the left rucaparib versus docetaxel, and then on the right rucaparib versus second-generation ARPIs. And as one would expect, there's a broader difference in progression-free survival in those patients who receive the second generation, the hazard ratio is 0.38, versus those patients who have received docetaxel, where it's 0.53. As we know, second generation or second switches with anti-androgens are generally not as effective as other treatments, although in select patients it may work. But for the most part, the progression-free survival is usually inferior to other treatments. So we said before that about a quarter of patients have DNA repair mutations. How can we then increase BRCA-ness? Is there synergy between BRCA agents, and can we make a patient who is HRD negative, HRD positive? So there are ways that we can enhance this, and enhancing blockade of androgen signaling is one way that we can do this. So there can be failure of AR-dependent localization of PARP to target genes. PARP-mediated nucleosome remodeling at target sites is abolished, and we know that this enhanced signaling can also cause transcriptional downregulation of AR targets. So inducing BRCA-ness will decrease HRR gene expression, decrease double-stranded DNA repair, and also potentially lead to radiosensitivity. There are other approaches besides using other hormonal agents. Anti-angiogenesis agents will also do something very, very similar. Although unfortunately we've not been able to prove that. We've actually looked at it at our institution with olaparib plus cediranib, and there are others that are looking at various combinations. But angiogenesis is another way of targeting this particular pathway. So 3 randomized trials that have looked at this particular question. Magnitude took patients who were pre-screened for their status. They had a variety of different HRR mutations, and there were 2 different cohorts. There were those patients who are HRR positive and the negative patients. We're trying to test the hypothesis in both groups of patients. Is there synergy between the two? And can you make a BRCA, non-BRCA patient or non-paired patient sensitive to the PARP inhibitors? So niraparib plus abiraterone and prednisone, both arms of the the positives and the negatives, and the placebo plus AARP, abiraterone prednisone is in the control arm. So the BRCA1, BRCA2s, it met its primary endpoint. There was a reduction in the risk of death by or progression by 47%, and this was seen by both central review as well as by by the investigator. The median follow-up at this presentation was 16.7 months. And as we would have seen in other situations, in pre-specified groups, there is a big difference in those patients who are BRCA positive. But however, this concept of synergy by trying to further anti-androgens along with the PARP inhibitors really did not show any difference. So in the negatives, the pre-specified early futility analysis showed no benefit. PROPEL, another trial looking at the same concept, olaparib plus abiraterone versus placebo plus abiraterone. RPFS was primary endpoint by investigator assessment. OS was a secondary endpoint. These patients were allowed to have docetaxel in the hormone-sensitive state. They could not have prior abiraterone. They could have had another NHA. And the question about sequential NHAs is, I think, very, very difficult in this situation. We don't have good data, but it was relatively a small number of patients. So as we see here, for the rPFS, there's a 34% reduction in the risk of progression or death with the combination compared to placebo plus abiraterone. The median rPFS difference was about 8 months. And again, we're seeing this difference in those patients who have the HR mutations, particularly seen in those BRCA1, BRCA2 patients. And this is the final overall survival analysis for all patients, hazard ratio of 0.81. TALPRO2, different PARP inhibitor, different anti-androgen. Again, we don't know the questions about cross-resistance in these situations. Talazoparib plus enzalutamide versus placebo plus enzalutamide. Again, patients were stratified based upon prior docetaxel, castration in the castration-sensitive state, and the HRR gene status. Primary endpoint was radiographic progression-free survival. Secondary endpoint, OS. As we see here, in those patients, this is by a central review, treating talazoparib plus enzalutamide showed a 37% reduction in the risk of progression or death. And this was predominantly seen in those patients who are HR deficient. There's about a 9-month improvement in the progression-free survival in favor of talazoparib plus enzalutamide. So these are indications, and I'm just going to go over the FDA for simplicity's sake. For niraparib plus abiraterone prednisone, adults with deleterious or suspected deleterious BRCA-mutated CRPC, olaparib plus abiraterone prednisone, same thing, BRCA-mutated CRPC, talazoparib plus enzalutamide, adults with HRD-mutated. It's a little bit of a broader spectrum of patients overall. So the big question is sequence, and we are using these drugs in the hormone-sensitive state. Should we still continue the anti-androgen when we add a PARP inhibitor in those patients of BRCA1, BRCA2, or of ATM? We don't know. We don't have a good answer. There's some interesting data that Maha Hussein has generated, where she did a 3-arm trial of abiraterone plus prednisone versus olaparib versus olaparib plus abiraterone and prednisone, and then arms 1 and R2, arms 2 could cross over at progression. And as we see here, as one would expect, the progression-free survival was best in those patients who had the combination therapy. And in crossover, at progression, 8 of 19 patients, these are small numbers, from abiraterone prednisone to olaparib, and then vice versa. We see that the median PFS from cross was about 8 months. If you crossed over to olaparib, if you crossed over to abiraterone, it's about 7 months. Median PFS from randomization, 16 months in both arms. So there does seem to be some interesting interaction between the two. Now, of course, in the theme that we were trying to move disease treatment up earlier, TALPRO3 is looking at the combination of talazoparib plus an anti-androgen plus ADT in patients who are hormone sensitive, and hopefully we'll have some data on this in the future. I believe this has been out in press release form, but not in full data form. So in conclusion, PARP inhibition for single agents is approved by the FDA in castrate-resistant disease. Different for rucaparib, you need a little bit more advanced treatment, anti-androgen plus docetaxel versus anti-androgen for olaparib. PARP inhibitors should be used because of what we see with that Triton-3 study, should be used prior to other cytotoxic agents in CRPC in those patients with BRCA1, BRCA2 positive. Combinations should be considered for BRCA2 mutations and perhaps for all of the HRD mutations with the combination of talazoparib plus enzalutamide. And combination therapy should be considered over sequential treatment. That's our conclusion. That's it. Thank you very much.